Hello, my name's Peter Hampson. I'm Clinical Director at the Association of Optometrists. Welcome to this lecture on infection control. This is a CET approved lecture, so we will be hitting the learning objective 2.12.1, which is understand how to create and keep a safe working environment for you, the practice staff, and your patients. At the end of this lecture, there will be some questions to obtain your CET, and passing that will result in the award of a certificate that you can print off and display to demonstrate to patients that you are following infection control processes. We're going to take a look at what is a coronavirus, how it spreads, and then focus on how to protect yourself and patients, paying attention to screening, respiratory health, hand hygiene, social distancing, PPE, cleaning and disinfecting, and then resources for practitioners. So first of all, the question is, what is a coronavirus? They are a group of similar RNA viruses, and they normally cause diseases in mammals and birds. In humans, they cause respiratory tract infections, as we have seen, and they're an enveloped virus that consists of a lipid bilayer with membrane envelope and spike proteins which are anchored to this. SARS-CoV-2 is the virus that causes COVID-19 in humans, but there have been other SARS viruses as well, and they obviously have different names. And people may be wondering, although probably not that many now, why it's so serious. And although the number of deaths due to COVID-19 is decreasing, it's still a very serious disease for its impact on the population, and we need to be cautious. And we'll cover a little more on that later as to why the caution is so important, but a lot of it is to do with how the disease spreads. And there's been a lot of talk in the press and on the news about R0, and that's the number of cases of a disease generated by one case. The naught really presumes that there is zero immunity, so at the onset of a new disease. And then as the disease progresses, this ceases to be true, and we start to refer to R rather than R0, which we've seen reflected in the government language. And really, it isn't about protecting yourself, it's about making sure the disease doesn't spread and infect others. And if we just look briefly at this graph, we can see that the rise in cases, if R just creeps up to 1.1, let alone back to the levels it was at the beginning of this disease, can lead to an acceleration in how many people have got it, the number of hospitalizations, and potentially the number of people that unfortunately will die of the disease. ONS data has been published for a while now, and if we look at the ONS data, we can see that anyone can catch this disease. There isn't a great difference between the young, the middle, and the older patients in regard to who catches it. But what we can see is that deaths are far more common in the older groups. And lots of patients in optical practices are older, and that puts potentially our main patient base at an increased risk of this disease, and reinforces why optical practices have to take this very seriously, because the people that we're seeing are potentially those that may have the worst outcomes from it. The spreading of the disease is mainly through respiratory droplets, and predominantly that is from symptomatic patients. When I say predominantly, I should say they are the ones that spread the disease the most, and that's normally within 2 meters. Direct contact with an infected person is still the most risky. Indirect contact via contact with contaminated objects and surfaces is also obviously a mechanism of transmission. There is some spread in other ways as well, and we will come to that. So, according to a paper from the Centre for Evidence-Based Medicine in Oxford, there are a fair proportion of patients that potentially are spreading either asymptomatically or at the very least pre-symptomatically with this disease. They've commented that actually the data out there is not great at the moment. There's quite a spread of numbers or ranges of how many people are spreading this disease without obvious symptoms. And the paper makes it clear that until we have widespread antibody testing, we won't know exactly how many people that has been. Estimates at the moment range between as little as 5% and as much as 80% of those who have tested positive might be asymptomatic at the point when they test positive. Some of those asymptomatic patients will later go on to be symptomatic, but that doesn't help if they're spreading it and we're unaware. So we need to now consider how long SARS-CoV, or in fact any diseases, really can survive on various surfaces. And a lot of the things we will talk about will actually relate to all infection control, not just to SARS-CoV. But in this instance, we are focusing on that. So when we look at the evidence again, we can see that on plastics, it can last for up to 72 hours. Stainless steel, around 48 hours. Cardboard, 24 hours. And copper, because of its antimicrobial properties, only as potentially as little as 4 hours. Unfortunately, that isn't something that we will see throughout practices, copper door handles and all sorts, but it will help to reduce that contact time. Unfortunately, again, most people will touch a door handle more often than every 4 hours in a common place, so it's worth thinking about. If we compare that to influenza or flu, H1N1 can survive for up to 48 hours in a viable form, again depending upon the surface. Unfortunately, these papers didn't necessarily look at the same surfaces, but there is some overlap. We can see that plastic in this case is 24 hours, stainless steel is 24 hours, and cloth is 8 hours. And that becomes important when we start thinking about things like fabric-covered chairs and practice soft furnishings and those sort of things, which is why those are important issues. On wood, it can live for up to 48 hours as well. So influenza not quite as bad as SARS-CoV-2 for survivability, but still significant. And we see influenza outbreaks of various strains most winters, so it's still worth being very aware of sort of the risk of this sort of disease spread. And another disease we see a lot of, particularly in the winter, is norovirus. And quite scarily, as much as obviously the norovirus doesn't have the same death rate as something like coronavirus does or SARS-CoV-2 does, we can see that it can live for up to 28 days on a wide variety of surfaces. And that has huge implications that if you've had a patient in who has been unwell with norovirus and they do still have active virus on them, or they're in that sort of contaminated phase, that could spread around and make a number of people very unwell. So again, those infection control procedures read through to not just relating to the current situation. A lot of people will think, well, why does this matter to optical practices? And again, another study looking at, and it's a very recent study actually, looking at a pre-COVID US optometry clinics, found a number of very interesting facts, and that was that more than half of them had no written hand hygiene policy. And 46% of them, or just over 46% of them, didn't wear gloves when examining patients with any form of eye discharge. 48.6% did not use droplet precautions for patients with respiratory symptoms. And I suspect that will change in this new world that we live in, but pre this it didn't. And also 68.4% just used 70% IPA or isopropyl alcohol to clean reusable tonometer probes. None of them used bleach. And although US optometry, it's different, it's still reasonable to presume that some of these issues will read across to UK optometry. It's unlikely that they are vastly different. And thinking about that cleaning of probes, if we look at the sort of disinfection of equipment and all sorts, the college guidance, again pre-COVID, which is important to stress, recommended sodium hypochlorite or a bleach-based solution. So obviously US guidance wasn't following that, and the guidance I believe was fairly similar. And I suspect some of those, we've become slightly relaxed about some of these procedures pre this in optometry as well. So the question then is, how do you protect yourself and patients? And one of the important things you can do is screen them. Obviously, as we've said, a number of patients will be asymptomatic, and that won't catch those patients. But it will catch those that are symptomatic or are likely to be symptomatic because they've been in contact with somebody with the disease. And as we know that those patients are the ones more likely to spread large volumes of the virus around, then by not seeing those patients, we can help to reduce risk. So asking patients when they're booking appointments whether they've got any of the symptoms of coronavirus, and that's the new continuous cough particularly, fever, and the more recently added symptom of loss of smell or taste will help to protect you. and also asking if any family members have had the disease or symptoms of the disease. And as much as the virus is now slightly less common, it's still very important to make certain that we're not placing ourselves at increased risk. There's been a lot of talk about temperature measurement and whether or not screening patients for temperature will do the job and is useful. And if we look at the World Health Organization, we can see that, and this was in relation to travel, granted, that temperature screening alone at entry or exit to airports is not an effective way to stop the international spread. And again, that goes back to this asymptomatic patient base, the fact that patients may have taken medication that are reducing their temperature so that they feel better themselves, so it may not catch them. So again, the screening questions are arguably more important. That's not to say that with consent you can't screen for temperatures, but we just need to be aware that temperature screening on its own is not going to necessarily be a catch-all to make certain that there's no risk to anyone. What is very important as well is good respiratory hygiene, and we've seen these posters throughout most of the press, the catch it, bin it, kill it regime. Staff shouldn't be at work if they are ill, in the same way that patients shouldn't be coming in. But on occasion, anyone can develop the symptoms of a cold or a virus partway through a working day. You start the day feeling something isn't quite right, and then halfway through the day you start coughing or sneezing or whatever. So if that happens, it's important that one, that staff member is removed from the workplace to reduce the risk to others, but also that they know how to make sure they cover their mouth and nose with a tissue and sneeze into that, and that to dispose of the tissue so that it's not spreading around, not using their hands, which again risk touching things and spreading the virus in that manner. And if for some reason a sneeze comes on, the advice of coughing or sneezing into the sleeve or the elbow is still good advice, because it will help to reduce the spread of the disease. Hand washing is probably the most important thing that anyone can do. If you have coughed or sneezed, if you have touched anything, and there is the risk of virus being on your hands, and that risk of then infecting yourself by touching something that goes by your mouth or your nose or whatever and spreads the virus, it reduces that risk and also stops you spreading it from site to site as well. And it's important that we encourage patients to also wash their hands as well. And there are a number of posters out there so that you can display them by the sinks. This one's from the World Health Organization, showing how you go about washing your hands, the proper process to actually make certain you get all parts. And it's important to make certain that staff are washing their hands when they get to work, in case they've picked up anything on transport or the door handle on the way in, regularly through the day, and also when they've been in contact with patients, and also when they're leaving, to avoid taking anything out. And importantly, as I said, to get patients to do this as well, we've produced a poster which you can print off and you can personalise in the small box at the bottom where you can put your practice logo. You can put them next to hand hygiene stations or alcohol gel stations, so that you can reinforce to patients the importance of washing their hands. More interesting research on hand hygiene. This is taken from a paper really aimed at hospital infections, and they talk about the 5 moments for hand hygiene. And they don't read across directly to optometry, but I think we can probably insert fairly good equivalents. So before touching a patient, so that seems quite logical, you wash your hands before interacting with the patient. Before a clean or aseptic procedure, well, we'll be doing a lot less of those in high street or community optometry. For our hospital colleagues, they will probably be doing that, and they will have hospital procedures to follow, no doubt, but it's still worth bearing in mind. And after body fluid exposure, well, in our case, that could be tears, it could be a discharge from the eyes, a mucus discharge. So obviously any contact with that, make sure you wash your hands to avoid the risk of spreading anything. After touching a patient, again, less likely, but you've got your hand on their face for Volk or something, there's a risk there, so washing hands after that before you start picking up pens, touching keyboards and all sorts, or if you can't wash them, using alcohol gel to make certain that they are okay. And obviously after touching a patient's surroundings, so particularly important potentially for our domiciliary colleagues, or if you are helping a patient on with their coat or picking up their bag for them and you may not necessarily consider that that's an infection risk, that's another place that could be spreading disease around without thinking about it. So it's just being aware that those risks exist. Now, there's been a lot of talk about social distancing, particularly in the workplace, And government guidance suggests that 2 metres should be maintained. We may see that change in coming weeks, we don't know yet. But still, that idea of keeping away from people as much as possible is important. And using floor markings to help people visualise that spread of 2 metres. People are quite poor, and we've probably all seen them walking along the streets at staying 2 metres apart. They don't quite get the gap that is important. So anything we can do to help that, and other mechanisms of one-way systems and screens and physical barriers to try and keep people apart will really help. In optical practices, because we have to interact with people quite closely for examinations and taking PDs and fitting frames and all sorts of things, we won't always be able to maintain 2 metres. And as such, PPE will be very important for us to enable us to be safe at work and all sorts, especially given the volume of asymptomatic patients that are out there. And if we look at social distancing, and this graph shows the work that was done by Ferguson, which informed some of the government work, and the second graph is some more recent work that's been done, and it shows the modelling on the US and the impact on death rates, and shows that with social distancing you can see that curve, as has been said by many, becomes flattened and really has an important part to play. It may be difficult in practices, but it will have a big impact on how the disease spreads. And as healthcare professionals, we have to be very aware of that and not become an outbreak centre or anything like that, which would be very damaging. And some more interesting research on social distancing showed that actually when R is lower, or in this case R0, when the disease is spreading less, actually workplace social distancing was more effective. So as much as this work looked at R0, and we've said that R is actually what we're talking about more because we've now got the disease with interventions, it's still important because actually that close interaction at work, when people are still staying away from pubs and restaurants and the other places where they may mix with lots of people, the interactions at work may well be where you spend the most time in a prolonged exposure to people that you're not normally living with or whatever. So keeping distance and taking appropriate procedures are going to be very important within the workplace, and it's important we all take that very seriously. Unfortunately, that does mean modifying some of the things that we all like to do. So the communal tea and coffee facilities are going to be very difficult because they pose a risk. Keyboards and computers, if you can just stick to your own, that's great, but it probably isn't practical in most practices. So most practices will have to share those, and that needs to be considered how that's done safely. But the decluttering of zones, removing papers and all sorts, just so that people aren't flicking through the same magazine from person to person, potentially spreading disease around. And if possible, having personalised tools, so whether that is your own screwdriver, your own PD rule or whatever, that you're not sharing with people. And that's important so that you're not spreading around anything that you've handled, but also you have a much better idea of when it was used last, how clean it is and all sorts of things, so that you can be aware of what's happening with it. When we get to PPE, there are sort of two different requirements really. There are PPE requirements if working closer than 2 metres and involved in direct patient care, and for staff working within 2 metres but not involved in direct patient care. And in the public health guidance, for those that are just working within 2 metres, and it uses the example of bus drivers, that just a fluid type 2R mask may well be okay, but for others, gloves, apron, type 2R mask, and then a goggle or a face visor once it's been risk assessed are recommended. If we look at the little graphic that we've got here, we can see that actually when you're 2 metres apart, it's a low risk. But if you're coming in closer than 2 metres for short periods, passing by or whatever, you can't maintain that sort of separation, then the risk is higher, but not high. But if you're in a prolonged contact period, then the risk is far higher. So that will be optometrists, that will be dispensing opticians if they are there for a length of time, working very close to patients, fitting frames and things like that as well. So in those instances, it's very important that the proper PPE is used. The AOP have produced a useful guide to PPE, which we will watch now.
Public Health England has clarified the PPE required for use in optical practice. To perform essential, urgent or emergency care on patients, you will require access to fluid-resistant Type 2R masks, eye protection, gloves and disposable plastic aprons. You should not be seeing patients who have COVID-19 or COVID-19 symptoms. Before seeing all other patients, you should conduct a risk assessment as to whether a face mask and eye protection are necessary. Consensus from optical bodies is that you should wear a face mask, apron and gloves in conjunction with using a large slit lamp breath protector. The recommendation is to not perform aerosol generating procedures such as BlephEx, algae brush, or non-contact tonometry. Instead, optometrists should use GAT or eye care tonometry. If you're working in the reception or communal area and cannot maintain 2 meters apart, you should wear a fluid-resistant Type 2R mask. Masks and eye protection may be used on a sessional basis as long as they are not contaminated. Gloves and aprons are single-use only and must be disposed of between patients. It is important to follow the correct procedure for putting on and removing PPE. This will protect you and your patient. The process for putting on PPE is to remove jewellery, tie back hair, wash hands, put on apron, put on face mask, mould the metal strip around the nose, put on eye protection if required, put on gloves. When taking off PPE, the process is to remove gloves, wash hands, remove apron, remove eye protection if worn, clean hands, remove face mask, clean hands.
The World Health Organization have an open course, and it talks about that glove use is an important part of protecting hands from contamination. If a healthcare worker is using gloves, it doesn't mean they don't need to perform hand hygiene. Gloves alone don't sort of solve that hand washing issue. You've still got to wash your hands, you've probably got to wash them as much if not more, and gloves should be used when you're in contact with infectious material. Thankfully, that will be fairly rare in optometric practice, and you must perform hand hygiene before you put the gloves on. Also, not wearing the same pair of gloves. They are a single use per patient item, not moving around. Otherwise, anything that is on the gloves is just transferred around from patient to patient or onto door handles and all sorts as well. So that's incredibly important. And again, when taking gloves off, as we've said, it's important that you make sure you perform good hand hygiene. It's also important that you make sure your hands are clean before you're getting gloves out of that shared box of gloves. We've all seen them. They come in a pack, a little bit like a tissue box sometimes. And putting a non-clean hand into that box means that then potentially that whole box of gloves is contaminated and leaves people at a risk that they don't necessarily know that they're exposed to. This poster on how to remove gloves is from the Health and Safety Executive. And we can see that it talks us through how to put them on and off, about pinching the outside of the glove near the wrist and peeling that glove down, and then holding it by the end of the glove, and then with the hand that is now ungloved, tucking it under the wristband and peeling that other glove down over the glove that you're still holding, and making sure that you don't touch the outside of the glove and risk contaminating your hands in that way, and then disposing of the gloves appropriately so that they aren't a risk to anyone else. And again, more studies that looked at hand hygiene and cross-infection, and this is in nurses and nursing assistants and in a hospital-based environment, so the risks are different, but the continued use of gloves without removal after contact with patients resulted in this setting 64% of all contacts being performed without adequate hand hygiene. And microbial transmission could have occurred in 18% or so of those contacts. Now, those numbers should be lower for optometric practice in a community setting because there will be less infectious patients potentially, but that's still quite significant. And when they looked at gloves in the hospital setting, they found that 86% of those gloves were positive for pathogenic bacteria. So that failure to change or remove contaminated gloves is a significant risk. Then when we turn to masks, we know that we need a type 2R mask. The R means that it's fluid resistant. These are the masks that practitioners would wear, not that we may ask patients to wear a face covering or anything like that. It's important that they meet BSEN 14683. And in this instance, we've referenced the 2019 guidance, but I believe the 2015 guidance was pretty much the same. Having used our PPE appropriately, we then need to dispose of it, and any potentially contaminated waste needs to be disposed of properly. You can't just simply put it in the normal waste, as it's a risk to others. So that gives you two options really, and one is arranging for a proper category B disposal, and that could be arranged through your waste management companies in the same way that we have our little yellow boxes for minims and things like that. Or you can go for the double bagging, so you bag the PP in one bag and then put that bag inside another bag, and you store it for 72 hours in a secure location. And then after 72 hours has passed, it can be disposed of via normal waste processors. If you are going to take that option, it's important that if you are then adding more waste to that room or anything, that you're aware of which bags are which, and you're not inadvertently putting the wrong waste out at the wrong point. So it's not a trivial process to do that, but it can be managed. It will depend on the size and shape of the practice and all sorts, the volume of PP you're generating, and for some it will be that you'll need a proper category B disposal to make certain that it can be sort of removed in a manner that lets you go about practicing safely. When we talk about sort of cleaning and disinfection, we really need to split it out into three categories. Cleaning is the physically removing of infectious agents and organic matter such as soil and dirt. It doesn't necessarily kill the virus or the bacteria or anything like that is there, and you can't disinfect or sterilise an unclean item. So if you're wiping makeup off the slit lamp chin rest or off the headrest, that's cleaning. But that doesn't necessarily mean you've disinfected it or sterilised it. Now, disinfection is the process of inactivating the actual pathogens, and low levels sort of eliminate bacteria and enveloped viruses. Higher level disinfection is effective against bacterial spores as well. Thankfully, we don't need to be considering that. So thankfully, fairly low level disinfection is going to work and achieve what we need to achieve here. Sterilisation is actually getting rid of all of the viable microorganisms, or at least pretty much all of them. And they talk about the sterility assurance level, and that means that the item is sterile enough that there's only a 1 in a million chance of an organism surviving. And if that's the case and that level has been met, then it can be considered sterile. So we need to think about how we know the disinfection process will remove enough of the virus. And this is a slightly geeky, slightly nerdy slide, but it's generally considered that if we get a log 3 or a 3 log reduction in viral load, then that's generally disinfected, and that's what we're aiming for in most studies. Of course, we should bear in mind that if there are a huge viral load, because we've got a symptomatic patient, then even removing 99.9% of the viruses could still mean that there are a lot of viable viruses there. But as we've said, that's not going to be that often in optometric practice, thankfully. But it is still worth bearing in mind, so that the better reduction in pathogen you can get, the better. But even at the highest levels or the higher levels, there can still be some viable virus there. It's just decreasing the risk to a manageable level. And that's true across all settings of healthcare. And the AOP published some guidance on cleaning and disinfection. I've seen this referenced in a couple of places, and I think most people have got this from this paper that is out there on hospital infections. And it shows that things that are effective generally are ethanol, 70% concentration or better. That needs to be in contact with what you want to disinfect for a minute though. So a quick wipe isn't enough. It needs to sit on there and dry. And that gets us that greater than 99.9% or a log 3 or better reduction. Sodium hypochlorite 0.1%, again similarly, and also sodium hypochlorite 0.5%. And one of the questions we've seen is, well, why are 0.1 and 0.5% the same? And the truth is that the threshold that they used was a greater than log 3 reduction. So 0.5 may well have achieved a greater reduction, but that was the cutoff that they used. But also they looked at 0.5% for larger areas, not sort of small areas, and cleaning those down. So for cleaning down small areas, they looked at 0.1%, so cleaning chin rests and things like that. If you're mopping the floor, then 0.5%, because there's a bigger area to cover and you need to make certain that you've got a slightly more of the active ingredient to be effective. What's important to remember though is that similar results were obtained with just disinfectant or detergents and sort of soaps effectively, and the soaps that contained sodium lauryl sulfate or alcohol polyglycosides and cocoa fatty acids were also really effective at getting rid of the virus. They need a longer contact time. Generally, they need sort of 5 minutes. So again, that's important that the contact time is appropriate. Obviously, when we're using soaps for washing our hands, we don't need that 5-minute contact time. And that's largely because we're not reliant on the soap sat on the virus to remove it. There's also the mechanical rubbing and the flowing water that will wash away the virus as well. So that's quite important. And when we think about how viruses are deactivated by these various products, we can see that soaps disrupt that lipid layer that we mentioned at the beginning, and that helps to break the virus apart. And then the soap has the action of trapping the broken parts, which helps them to be washed away. Alcohol gels work in a similar way. They disrupt that lipid layer and break it up. Obviously, you don't get the same rinsing that you get with washing your hands under water or whatever. But obviously, if it's sat in contact with the virus on a surface, then you do get a similar impact. Bleach also will disrupt the lipid layer a bit, but importantly, bleach has a slightly different mechanism of action, and that is it attacks the RNA of the virus and it stops it from working. So it's a slightly different mode of action. What's important is that these things are all effective if used appropriately. Antimicrobial wipes with the correct ingredients can also be used, but you do need to make certain that they do have the correct ingredients. If it doesn't contain 70% alcohol, then you need to make certain that it has been rated for killing coronaviruses, particularly at the moment. And Clinell wipes have been, they predominantly use benzalkonium chloride, but they are rated for coronaviruses, and if you go onto their website, you can see that they have information on the sort of studies that have been done to show that it is effective against coronavirus. But you need to make certain what you're using is effective. Things like baby wipes, when you actually look at them, contain very little active ingredient. They predominantly have a bit of water and a bit of scent and all sorts in them. So just thinking it's a wipe and that will be okay isn't going to be good enough. You need to make certain that it does actually have the correct ingredients in there, and that's really, really important. And when you are cleaning and disinfecting, it's important that you declutter and you remove things that are hard to clean, because it's difficult to clean if there are lots of point of sale and lots of magazines and things like that around. And also when you are cleaning, sort of working your way from the top down to the bottom so that you're not wiping things back up the object that you're cleaning, so sort of a top-down approach for cleaning. When we think about soft furnishings, again, if we think back to how long the influenza virus could survive on cloth, it was significant. So that's very difficult then to wipe clean. Soft furnishings aren't going to react overly well to constantly being soaked in soap and water. They're going to be soggy if nothing else. And using bleach-based products is very likely to damage them. So covering them with something that is wiped clean is one option. Replacing them in the short term with something that is wiped clean is another option. And it may be that long term you move to sort of more sort of hard wearing surfaces that are easier to wipe down. It's important that practices have a cleaning schedule and that you clean anything that is in contact with patients, and that's done after each contact, or staff as well for that matter. And displaying posters or notices to reinforce the need for hygiene measures. The AOP have produced some useful resources, and I will talk about those in a little while. But when we're thinking about sort of commonly touched items or things that the patient is breathing into, such as the field screener, it's important that those areas are wiped down, and I know that a number of field screener manufacturers now have produced guidance on how to clean the inside of their field screeners. I think for now probably the best advice is to use it very much on a clinical indication basis, and then you'll minimise that clean down time. Obviously, clinical equipment that is in contact with the patient is going to need cleaning and disinfecting, so trial frames, phoropter heads, slit lamps, fundus cameras, OCTs, all of those things where the patient's chin is on and all sorts, and you may have added breath shields to them and similar. They're going to need cleaning down and wiping down to make certain that they are clean in between patients. This is going to add a lot of additional time. And common touch points, so handles, desks, the arms of chairs where the patient has lifted themselves up, and pens if you need to use them, keyboards and mice, and adding stickers to the keyboard to remind staff that if they are shared with other people, that they need wiping down with a suitable cleaning wipe before and after use, just to protect each other. The protective screens that a number of people are putting up and have been, you can get from a number of manufacturers now, they are going to be very helpful, I think, to protect staff members. But it's important to remember that they also need cleaning, because dependent on whether people have masks on or not, or people are touching them, they're going to need cleaning so that they don't just act as a reservoir for the virus to build up on, or for any pathogens to build up on. Thinking about switches and keypads, whether that's the card machine terminal that you're needing people to use, or whether it's the light switches and things like that. So those are all things, common touch points that are going to need cleaning to make certain that the practice is clean and safe and isn't going to spread any disease. And also spectacle frames, so frames that have been tried on, not letting patients just randomly try them on without supervision so that they can go back on and you're uncertain. We've seen in government guidance that clothes shops aren't to permit that sort of thing, they need to keep them separate. Obviously that is going to apply to optics as well. So we need to make certain we have a process for that, whether that is supervised trying on of frames, whether we take the frames from display for patients and bring them to them so that we can monitor that process. And then a process to clean those frames, to disinfect those frames before they go back onto display so that somebody else can come into contact with them. And when thinking about disinfecting frames, one of the hot topics at the moment has been UV disinfection. UV disinfection has existed for quite a while and works using UVC in the range of 100 to 280 nanometers, and that inactivates pathogens by damaging the RNA or DNA, depending on the pathogen. The genetic material absorbs the wavelengths of light and they become inactivated by that process. There aren't really any studies on SARS-CoV-2, and that's not really a shock. It's still a very new disease at this point in time. But there are studies on SARS-CoV-1, and we can draw a reasonable comparison from those studies. And there's a very good piece of work on estimating UV sterilisation dosage. And we can see that within that, they refer to these values of D90 and D99.9 and 99.9 and so on. And it's important to understand what those mean so that we know what we need to be doing or what we don't need to be doing. And if we think back to our log reductions, then D90 is 1 log or log 1, and D99.9 is our log 3 reduction. And that's where we've said is sort of our minimum level. So more than that is good. When we look at this paper, we can see that they tested for different levels. So we can see the D90 sort of dosage or time that was required, and D99.9 and higher. And the CDC in America recommends the level of 10,000. So we'll look at sort of what 10,000 joules per meter squared means. And it really gives us an idea of how long it takes to inactivate a suitable amount of the virus. And a number of these UV sterilizers talk about a 90-second disinfection process. And we're just going to think a little bit about whether that is possible. And as with most things in life, it's a bit more complicated than that. So there are a number of factors that influence how long it takes to achieve the required disinfection. And that includes the power of the UVC bulb, how many watts it puts out, how old the bulb is it still functioning as efficiently as it did when it was new, has it lost any of its output, has it worn, is it sort of now not functioning as it once was. The temperature which the bulb is operating at, a lot of these bulbs will be influenced by whether they are cold or whether they are hot and how efficiently they operate at various points. And shadowing, which is a really important point for consideration with regard to spectacle frames. Is an object in the chamber stopping light reaching either another part of the object or another object within it? So if you've got multiple spectacle frames in there, is one of them blocking the light getting to the other one and therefore decreasing the effectivity of the UVC on the other items that are in the cabinet? And then also how close the object is to the light source. And as the object moves closer to the light source, we find that actually that has a big impact on not just the dose that's achieved, but also the shadowing. If we look at this fairly basic ray diagram that we've drawn, we can see that as the object moves closer to a light source, and this is an area light source, so it's drawn in that way, we can see that the closer the object is to it, the greater the shadow it casts, but also the greater partial shadow that it casts. And that's very important to consider. So there is a relationship between moving the object closer to the light source and the dose that we can deliver, but also how will that impact what else is going on. And to have a look at that, we can do a little bit of maths. And that comes from this paper by Arguelles that I referenced before with the dosages. And within that, the maths is broken down into that the dose is achieved by how long, well, what intensity is there and how long the intensity is delivered for. And that gives us our dose. And then we can model the intensity based upon an attenuation factor, which is how much of the light actually from the bulb gets to the surface, the power rating of the bulb, because that will be important, and then physically how far away the object that we're trying to disinfect is from that bulb as well. And we can model that to achieve some various results. And if we take a look at those, we can see that as the bulb power increases, the time required decreases. So that's helpful. We can also see that the time required varies depending on which dose we're going for. So if we're going for 6,020 joules per meter squared, which is your 99.9, we have a table. And if we're going for 10,000, which is the CDC recommended dose, we have another table. And then we also have these two distances, so whether the object is quite close to the light source or quite far away from the light source. And as the object gets closer to it, we can see the dose goes up quite quickly. But as we've said, as the object gets closer, the shadowing and the casting of shadows on other objects increases and starts to have implications for whether items are sat hidden from the effective rays. Looking at the 90-second claim, we can see that if we've got quite a strong bulb at 35 watts and it's quite close to the light source, even for the higher dose, 90 seconds is feasible. Definitely feasible. And for the lower dose, even with a lower wattage of bulb, we can also see that around 90 seconds, 95 seconds is also feasible. So that's quite reassuring. But spectacle frames are complex shapes, and obviously sides and the inside of rims and all sorts, nose pads and things like that have been in contact with patients. We need to consider whether they are getting exposed properly to the light, and we need to be aware of the limitations of the technology that we are using. As much as I think the 90 seconds is definitely possible, I've seen a number of manufacturers that have talked about much more of a belt and braces approach to how to disinfect frames. And in those cases, it revolves around pre-wiping them with a suitable disinfecting wipe, whether that's one of the Clinell type wipes or an alcohol-based wipe at 70%, to remove what you can, and then putting them into the UVC disinfection chamber for a longer time period. And that to me seems like a very good piece of advice and a very sensible way to go about trying to make certain that you're getting rid of as much virus as possible. UVC is very likely to be a useful tool when used with other disinfection techniques, but we do need to be aware that we can't just rely on it on these quick doses. And there's very likely also to be a difference between the more industrial grade products that some of the manufacturers will be providing compared to some of the cheaper, sort of potentially less quality assured products that you might find on Amazon or eBay. And when making a purchase, you should consider how many light sources it has if you're going to go down the route of UV disinfection. Does it have lights at the top and at the bottom? Because that will help with the shadowing challenge. What wattage is it going to put out? Can you space objects within it suitably so that you're not overlapping them and blocking other items? That will be very important. And also you'll need to make certain that any material that you're using is safe and isn't going to be damaged and isn't going to be degraded by exposure to UV. And really you're going to need to check with the various manufacturers over whether they're recommending UVC for their products. For metal-based products, it's probably fairly safe. So for metal frames and for tools and things like that, so screwdrivers, that shouldn't be a huge challenge. For some of the acetate-based frames or made of things like TR90, you will need to just check with the manufacturers whether they are rating their frames for suitable with that. I didn't think I would need to talk about not using UV radiation on your skin because I thought it was fairly obvious that would be damaging and should be avoided. But in light of some things that have happened in the press in more recent times, I think it's probably a good idea that I reinforce the fact that it's not to be used for disinfecting hands or anything like that because it poses a serious risk to those involved. And then one final point is that practices are going to be operating differently for quite some time, and patients as yet haven't potentially had a chance to get used to these new arrangements. So it's very important as a step to help with hygiene and managing disinfection risks within practices that we let patients know what the changes are going to be in practice and how we're going to do things a little differently. And one of the ways you can do that is by displaying some of the posters that the AOP has produced. And we've got posters that you can personalise for, as I've said, hand hygiene, and to let people know what they will have to do when they arrive, about making certain they don't have symptoms, they need to book an appointment, and this new process about sanitising their hands and all sorts, and that we will be enforcing social distancing, and that you may require them to wear a face mask or a face covering, and I think we've got a version with and without that, so you can go with whichever one suits you. And then also leaflets that we've got some DL sized leaflets and some A4 leaflets that you can print off and send to patients, or the DL ones particularly you can get printed with your logo on and send to patients with your contact details on when you're potentially sending out reminders. So that will just help to let them get used to the new way that you're going to be doing things. And we've also got an email template as well, and hopefully that will make all of this process a lot more straightforward and a lot less troublesome for patients and for practitioners going forwards. Thank you very much for listening.